And you'll notice that the transcript is running. If you prefer to see the transcript or not, you can toggle off and on using the live transcript icon at the bottom of your screen. Dr. Maffioli has graciously agreed to take questions during her presentation. So we'll use about 50 minutes in total for her presentation and questions during the presentation. Whatever time is remaining at the end of her presentation, we can use for general Q&A. We'll leave the last 15 minutes for a professional development meeting with our trainees. So we'll close out the session for general attendees at about 12:55. So now I'll transition to our introduction. Dr. Maffioli is an assistant professor at the Department of Health Management and Policy here at the University of Michigan School of Public Health. She received her PhD in economics from Duke University in 2018. Her research is in development economics, health economics, and political economy, with a focus on infectious disease, maternal and child health, and nutrition in lower income countries. She's currently working in Liberia, Myanmar, Brazil, Mozambique, and Nigeria. And she has also conducted research in Lesotho, Kenya, and India. Reflecting her interdisciplinary approach, her recent work has appeared in publications reaching a variety of disciplines, including the Journal of Development Economics, Health Policy and Planning, and American Journal of Tropical Medicine and Hygiene. We're very pleased to have her joining us today for her presentation titled, "Is the Phone Mightier Than the Virus? Cell Phone Access and Epidemic Containment Efforts." As I mentioned, Dr. Maffioli is taking questions as she goes. And so if you would like to just unmute and ask questions, she's open to that. You can also post a question in chat or raise your hand and I'll signal to her that you have a question. So with that, I will hand things over. So thank you, Dr. Maffioli, for your presentation.
Thank you, Paula. I will just, as Paula said, please feel free to interrupt me anytime. Otherwise, we'll keep an eye on the chat. This is joint work with Robert Gonzalez at the Georgia Institute of Technology. So let me just start and jump right in. So I think by now everyone is very familiar with infectious diseases outbreak that remain a major burden, especially in low and middle income countries. There was a variety of outbreaks, like the swine flu, the West African Ebola epidemic, the Zika virus back in 2015 and 16, and now we're kind of dealing with COVID. And so these infectious diseases will not stop, unfortunately, and so it remains important from a policy perspective to think about tools that can help contain the spread of diseases. Mobile phone technology have the potential to be such of a tool, and it's been used quite commonly during epidemics to either do diagnosis, to predict where an epidemic will spread, to improve the delivery of healthcare, as well as commonly used for information, whether that's sharing or kind of monitoring the epidemic or doing surveillance. Most of the research are really focused on specific tools and specific mobile app, for example, and the impacts of those specific mobile app on different outcomes. But the question that we're trying to ask today is a little bit broader, and is whether cell phone access among the general population really help contain or potentially spread the disease during an outbreak. Just to give you a brief, short overview, we're doing that in the context of the 2014 Ebola virus disease epidemic in Liberia. Going forward, I will always refer to EVD, so you always see this acronym. We will also use mobile phone coverage as a proxy for cell phone access, and we will use as a research design the regression discontinuity approach. So the ultimate objective of the project is to find the causal effects of cell phone access on the likelihood that a village has an Ebola case. I will tell you everything much more in details, but let me first think about what are the mechanisms that could explain this relationship between cell phone access and a disease. And ex ante, the relationship between cell phone access and a disease, whether that's Ebola or other diseases, is ambiguous. So on one hand, we can think that cell phone access can actually improve the likelihood of having Ebola or kind of help spread the disease. We refer to this channel as a network channel. There is quite of evidence that having a cell phone access, having a cell phone, increase access to the network, whether it's family, neighbor, or friends. You are more connected within your network. That could improve collective action, coordination, improving monitoring. But ultimately, during an epidemic, you might rely on your network much more often. And during the Ebola epidemic in West Africa, that was especially true at early stages of the epidemic, where the government couldn't do much. There was not much funding to respond, as well as basically most of the efforts that were really implemented to address the epidemic were sharing information. And so if that's the case, and people rely on their cell phone access and rely on their network, and these actually increase potentially also person-to-person interaction within the network, then it's possible that cell phone access actually spread or help spreading the disease. The opposite is true in case there is an improvement in exposure to what we call care. And so we have a couple of care channels, whether that's preventive care or treatment in general. We think that cell phone access can actually decrease the spread of disease, reduce the spread of the disease, because cell phone access can help getting information, getting help, whether that's to get more preventive care, through kind of material or hygiene practices, or potentially improve also getting access to treatment. So during the Ebola epidemic, for example, you could request an ambulance, you could request reporting, or you could request some help and to get sick and dead people that were already showing symptoms and infection, signal of infections. So we'll try to explore this mechanism as well, and try to think about how we can explain this relationship and in which direction the relationship goes. This project contributes to a variety of strands in the literature. The first one is really the literature in economics that look at the impacts on information and communication technology on economic development. There are a variety of articles on market efficiency and price dispersion, the impact on education, and also mobile money, especially in Africa. We also relate our paper to the literature looking at the relationship between mobile phones and health-related outcomes. There is evidence that mobile phone help with the management of health records, improving the quality and monitoring of care. There are impacts on health outcomes, and also there is a lot of evidence using mobile phones to do remote diagnosis of a certain disease. A third strand of the literature that we contributed to is kind of the literature that look at the relationship between mobile phone and infectious diseases. There are quite a few articles that study mobility patterns and migration patterns to predict where the outbreak would be more likely to spread and to evolve. And also, especially in public health, there is quite of a literature on what is called participatory epidemiology. That in practice means using mobile phone as an information tool, whether that's to do diagnosis or monitoring and surveillance more general. And from an empirical point of view, there is also a lot of literature on using radio propagation model to proxy for media exposure and to look at the impact of media exposure. We kind of get the flavor from these papers and try to use a different model, still a radio propagation model, but to predict cell phone coverage. And I'm going to tell you a lot of the details about it. And so we kind of add to that literature in terms of our strategy, our model, and we use that the output of that model within the regression discontinuity design. So we think our paper advanced literature in 4 areas. We first measure mobile phone access at a much larger country-wide scale in the entire Liberia, rather than just focusing on a specific tool or application and what's the effect of that mobile, having a specific mobile phone app on a certain outcome. We also try to address the endogeneity of cell phone access. A lot of the paper, especially in public health, kind of compare individuals with cell phone access, individual without, but there are a lot of different determinants of a person deciding to having a phone or use that phone compared to not use it. And so we'll try to disentangle the effect of mobile phone access from the effects of all these other determinants of the technology. We think we go beyond the evaluation exercise in the sense that we don't stop of looking at the direction of the relationship, but we also try to explore the mechanism that I briefly discussed before. And finally, we explore the effectiveness of this technology during a health crisis. And specifically, our setting is characterized by general mistrust toward a variety of institutions, especially the government and international institutions. And we do that during an epidemic, during a health crisis compared to normal times. So this is my roadmap. I'm going to give you a little bit of details on the background, very briefly, discuss about the data. Then I spend a lot of time on the empirical strategy and telling you a little bit more about the model that we use. I will go to the results and the mechanism, then think about policy implication. Let me get started on the Ebola epidemic in Liberia. I think these numbers right now appear so small compared to what we have been facing in the past 1.5 years, but you have to keep in mind that the countries that have been affected by Ebola in West Africa are pretty small. And actually in 2014, the Ebola epidemic was the largest epidemic in the history of this disease. So in Liberia specifically, 11,000 people had Ebola, either confirmed, probable, or suspected case. About 5,000 died because of the virus, and this was the highest number among the 3 West African countries affected. Just to give you a sense of what happened, international aid arrived, but arrived pretty late. Some funds were committed, but the government tried to keep control of and ownership of the relief effort. There were a variety of interventions. A hotline was set up. I'm going to tell you about that. Community care center, Ebola treatment units, and burial team were sent out to help through safe burial and kind of limited the infection after the person died. The data that I have really focused on basically the main wave of the epidemic. From March 2014 to May 2015. After that, basically the epidemic was over. There were 2 outbreaks, very minor, one in July, one in December 2015, but the epidemic was completely over in January 2016. So this is the study period that we use that we look at in this project. You have the timeline on the x-axis and a number of Ebola cases on the y-axis. The peak of the epidemic corresponded to between September and October 2014. Basically, the epidemic started in March, but it kind of exploded when the cases reached the capital city, where about 30% of the population live. Before the peak, basically, the government tried to do its best with the resources that it had. It closed the border, the school, and imposed curfew hours, but ultimately the real response arrived after when international partners, especially the US, were able to provide resources. So a lot of the response in terms of building Ebola treatment units, community care center, and treatment really happened in the second part of the epidemic. And by early 2015, basically restrictions were lifted and life went back to normal. In the paper, we use specific proprietary data that I was able to gather from the Ministry of Health. The data set that I'm using contain about 20,000 patients that were tested for Ebola in the study period. We also were able to gather additional data from another development organization that managed all the burials after July 2014 that give us a sense of where people were developed their symptoms, in which village. So we're able to manually kind of clean all this data and link the data to the census and create a measure of Ebola at the village level. And so for the paper and for the talk, we define a measure of Ebola, whether a village has at least one probable, confirmed, or dead case that was recording during the study period. There are alternative measures that we use also on the extensive margin, but this is, sorry, on the intensive margin, but this is the simplest that we use throughout the paper. So it's just a dummy yes or no, whether there was a case or not. In terms of coverage or cell phone coverage, we also were able to obtain data from the Liberia Telecommunication Authority before the epidemic in 2013 on the tower location and the radio frequency for all the tower in Liberia for the main, or almost all, for the two main phone companies that cover about 90% of the market. What we are interested in and what we will use also in the project is to measure, is a measure of signal strength on the ground. And we do that, or we obtain that through an irregular terrain model. So the model that we use is a radio wave propagation model that really predicts signal strength, so coverage, cell phone coverage in each point in Liberia. This is so-called the fourth generation model, in the sense that originally a lot of these models really just focus on whether there was a radio or not in a certain district, let's say, or they establish a radius around the tower, but they never really consider all these different characteristics of the tower, characteristic of the receivers, topography, climate, conductivity of the terrain. And so this is the most advanced model that we could use that consider more than 30 inputs. Is also one of the best model or better suited for the super high frequency radio waves that are the waves, the frequency waves for mobile phone that are different than the frequency wave for TV or radio, for example. And also the model prediction have been validated via on-the-ground measurement multiple times, multiple papers. And in fact, this is one of the models that's been used from the regulatory agencies, including the US, or also in the private sector to predict signal strength. The first thing I wanted to show you before telling you a little bit more about all the details of the model and how we get that signal strength and all the caveats associated to it is whether kind of should we care about, we should care about accounting for topography and all these different characteristics. So I want to show a comparison between what is called a free space terrain model and what we actually do, that is a terrain model that accounts for topography. So what you can see here is just an example of a part of Liberia. The green dots represent towers, and this is kind of the output of the free space terrain model that predicts the signal strength just based on the direct line of sight between the tower and the phone. And basically what it predicts is that, close to the tower, there is a high coverage, and then going farther away, there is less and less. But when we do account for all the different characteristics of the terrain, whether there is a forest or whether there is a certain slope or they are a certain elevation, and all the characteristics, the ground conductivity and so on, the model is very, very different and much more details. And so this is the model that we use. As you can see, there are so many different, diffraction or things that can happen in the terrain that make the coverage very, very different. And so we are using this type of model that account for all these different characteristics and specifically also topography. So the model used as an input, as I was telling you, the location of the tower, the elevation model, transmission frequency of the tower, as well as a lot of other variables. So it's much more kind of granular in terms of what is the coverage, the signal strength in each location. And the output that kind of create is the power received at any point in the ground that is measured in decimal milliwatts. So the output is usually expressed between, in a range between -50 and -140 decibel milliwatt. For simplicity, kind of going forward, we just use the absolute value 50 to 140. And so when you see 50 that indicate lower decimal milliwatt, and in practice, it means there is stronger coverage. And so as I showed you before, for example, there is stronger coverage, 50 to 95, closer to the tower, and then it goes kind of decreasing, going a little bit farther. This is Liberia, and these are the towers. The capital city is the star here, is Monrovia. A lot of the economic activity are concentrated here. There is nothing kind of in the north, it's mainly forest, as well as here in the south. So we predict the signal strength around each of these towers. And this is kind of what our model predicts and what we'll use as a measure of coverage in our model. So we estimate the effect of cell phone coverage using this output from the terrain model. And I wanted to give you a little bit of sense of what does that mean. And so the cell phone, you want to think about the measure of coverage as a kind of continuous function. You can imagine when you use your phone, you have bars from, I don't know, 1 to 5. And so what the model predicts is whether we do have power to kind of signal strength to have enough coverage, to make a call or to send an SMS. And so there is a range in which the receive power works. So that's usually between 95 and 105. Most of the literature use 95, and I don't have time to go through it, but we also have different, about kind of 3 tests that we run within the range, between 80 and 110, to try to find out what is the right appropriate cutoff that we can use within our setting. And that's also all the evidence directs to 95. That's usually kind of the cutoff that is standard for the type of cell phone network that exists in Liberia, that at that point in time was still 2G. And so what we are estimating is basically, or what we are using for the regression discontinuity design is a cutoff 95 decimal milliwatts that really indicate whether you can go from no bars to 1 bar, whether there is coverage, there is no coverage, you cannot make any call or send a text message, and whether actually you have 1 bar and you can attempt to do a call. And so we'll use that as a discontinuity in our regression discontinuity design. So the first thing we do is to compare villages or location within that within a margin around that threshold. And so what we want to show is that if villages are close enough, then there are not many differences. The only difference that we see are changes in the topography, and that's exactly kind of related to the prediction of the signal strength. I did see a raised hand, so I think it's Michael. Please go ahead.
Hi, Elisa. This is really interesting. So one of the things that I was noticing with your maps, and I'm trying to think about this applying to the identification assumptions that you're going to use, the topography kind of influence and map seem to have a lot of kind of variation in signal strength within short distances. I have a little bit of a clearer sense of thinking about the identification in the kind of standard map that you were showing, where kind of signal strength is going out, and at a certain point you hit a threshold where you can no longer kind of carry calls, and then you think kind of the characteristics are kind of smooth through that signal strength map. With the topography map, it's like characteristics are going to change very quickly in short amounts of space, and so I'm having a little bit of a harder time thinking through how this maps into the RD research design context.
Yes, so I think let me just try to explain a little bit more. That's correct. So this model is very precise. So as you're saying, it's considering all the different changes in the topography. So what we are trying is kind of so the boundary is less clear, is less clean. I think, if we use, for example, the free space model, you have a very clear line of where that boundary is, right? You have the red radius and then the orange radius, and that's where the boundary will be. Here is a little bit more fuzzy in that sense, that you have so many variations. So what we use is like villages that are on one side or the other side of the boundary, but the boundary is less kind of linear or clean, or it doesn't have a clear shape in that sense. And so we just use that as a cutoff of the regression discontinuity. But you're right that if you are in some part of the village, it might be looking different than in another part of the village. That does it make sense? I don't know whether this is addressing your point.
Yeah, maybe I can see the rest of your analysis and we can go from there.
Yeah, the other thing that I want to add is that so that's the whole point of using this model, is like making sure that we're able to capture just the idiosyncratic changes in the topography. That's what we want our identification to come from, like our phone coverage to come from. So I will show you a little bit later, but we also try to control for this free space. So let's imagine we are taking out our estimated coverage from the free space model. Everything that is left are all these subtle changes in the slope or the elevation. Actually, most of it is coming from slope. And so we'll see whether, so we're just exploiting that to estimate cell phone coverage. Yeah, I don't know whether that's helpful or confusing, but let me, feel free to ask more questions if this is not becoming clear. So basically what I just wanted to show you very briefly is that so these are kind of the prediction of what determines coverage, what determines signal strength. We predict that through topography control, demographic control, economic control. So there are some differences, right, in when we consider our full sample of villages. But the key here is that when we restrict close to the boundary, specifically, we use 10 decimal milliwatt. That's the optimal bandwidth that our model will tell us. But the villages are getting closer and closer. They're getting more and more similar. And so we are comparing villages that are on average similar on one side of the boundary and on the other side of the boundary, some that have coverage and some that do not have coverage. The only thing that remains significant is slope. So we'll control for that, and I mean, things will not change. But that's the topography is what's really different. Make those villages with coverage, without coverage, different. Sorry, this is what I wanted to show you indeed. And so basically we are comparing all our specification is getting at the local effect, right? Close to the villages, close to this cutoff, to this boundary. So I think I already kind of said that, but we are exploiting that discontinuity and the ability to make the call. And so our regression discontinuity design uses a receive power, like the signal strength that the model predicts as the forcing variable, and the receiver sensitivity as the cutoff. And so we use 95, and that's kind of where the evidence and the literature and everything that has been done using this method really estimate to be the right cutoff. So this is our empirical strategy and our regression discontinuity approach. So our outcome of interest is an Ebola indicator, whether the village has at least one case or not. That's a function of whether the village has coverage, that's what we are interested in. We also control for a receive power in decimal milliwatt net of the cutoff, the actual receive power that there is in that location, and that we usually assume as we use a local linear regression, but we also have alternative specification I'm going to show you in the results, and then we control for a function of the topography, mainly an elevation or terrain slope, also kind of a linear and kind of third degree or fourth degree polynomial. The bandwidth chosen optimally following canonical is about 10 decimal milliwatts. That's why I show you the 10 decimal milliwatts range. We use the triangular weight in kernel, and the standard error are clustered at the district level. That is a little bit higher than the village. So what we are interested in is beta. So whether there is a causal effect of having cell phone coverage on having an Ebola case at the village level. And that's kind of, we can estimate that whether we can satisfy certain assumption. So I already show you that the baseline characteristics are similar across the threshold. You can do that with plotting the covariates and looking whether the transition is smooth at the cutoff. We also show that the density of the forcing variable is smooth and there is no manipulation of the forcing variable. So you can find all the tests in the paper. So the first thing I wanted to show you right away is whether we do see that there is a discontinuous change in the likelihood of Ebola at the cutoff when we look just at the graph. And so here is the graph, is a little bit, the bandwidth is a little bit larger, but you can reproduce that using the 20 or 10 decimal milliwatts. So you have the signal strength on the x-axis that has been normalized. So 0 represents the 95 decimal milliwatt. So above that on the right are villages that are have coverage, and below that there is no coverage. And on the y-axis you have the probability that that village has at least one Ebola case. So what you can see here is that the first thing that you can see is that there is some sort of increasing relationship, and this is not surprising in the sense that in places where there is higher coverage, usually are also, these places are also places that are more urban. And so these are places where actually, because of the high densely populated areas, are also places where there were more Ebola cases and the epidemic spread more. But what you can see immediately, there is a jump at the cutoff. And so villages with phone coverage are about 10 percentage points less likely to have Ebola than places without phone coverage. So I'm going to show you the same kind of jump through different regressions. So our outcome is still this dummy, whether there is at least one case or not. We have different specification, our usual baseline specification. We have adding controls. We also change how we define the topography, the function of the topography, rather than linear through a polynomial. And then we also look at increasing the bandwidth so that we increase the sample size, changing the kernel choice, and estimating a probit model. Oid, please go ahead. Sorry.
Thanks, Elisa. This is sort of following up on what Mike said. I guess the question is, do you have, I think it would be helpful for your case to have something like a first stage here to start with. Mm-hmm. That is to say, some measure of actual time, or maybe do people in these villages not use phones, or if you tried to call them, that the call wouldn't go through, or some such thing. I think I'm stuck with, I'll say it more directly, kind of the implausibility of the assumption that the cutoff is as precise as you suggest. You know, I mean, the number of bars on my phone at my house, if I was sitting in my house, kind of goes up and down during the day. And so I think of the relationships you described as fundamentally more stochastic. Mm-hmm. And I confess that I may be wrong about that, but I think I would want to either see more evidence from engineering expertise or something that would actually tell us about the accessibility, or whatever the word is, the connectability or whatever in those particular places.
Yeah, those are all, I think that's kind of the pushback we are getting. And I think that's, so it's, if you look at the engineering literature, maybe we should report that more. 95 is the cutoff that's used. That's used because of the type of network that's used and it's been validated. So we started that way of using 95. And then we agree with you that, you know, it's much more, is a continuous function, right? And so grading that cutoff is not so, I mean, there might be some difference, some might be 96 or 94 or something else. And so we did this test to check, to kind of search for the right cutoff within our setting, and all the evidence through kind of the engineering methods. And we find that actually that's also where we see the jump. And so there is evidence on that. That's kind of the common standard cutoff that have been used from regulatory agency has been validated and so on. But I do see your concern. I think one other thing that I want to say to try to address that, we can probably provide more evidence on use of phone for villages with coverage, without coverage. The other thing that we did also is, what we were very worried about is also villages that, or like people that might have a phone but do not have phone coverage, or maybe the phone doesn't work in their village yet. And then they walk over to another village, or as you said, you're moving within your house and just try to get that coverage to make the call. So we're also and I should have them later, but we also add some robustness check to see whether if we restrict our analysis to villages that are very close to each other, let's say they are a walkable distance, whether the results change. And so try to address that problem of just walking over or change your position to get cell phone coverage and make the call.
Well, they also aren't stuck in the ground like trees, right? That they might go take a bus or a van to work elsewhere or to go to the market, in which case their phone might work better.
Yes. So these are all intention to treat effects, right? They're all people that are the kind of people that have access to cell phone coverage. What the impact of those people is on that living in a certain village with cell phone coverage on Ebola. So he's right, there might be people that actually can use it or not, or can use it when they go to the market or not, even if they are assigned. So the estimates are in intention to treat to start from.
I wanted to follow up on Hoyt's question, if it's okay, as maybe another way of phrasing this. So one thing is there can be kind of control group contamination in the behavior that you and Hoyt are discussing about people moving around. So people who are below the cutoff might find ways to get access intentionally to cell phone coverage. Another thing is that your forcing variable is the product of a model, which is kind of as good as the input values are. And we would think that there should just naturally be some measurement error there in terms of what actual received power is or whatever in a local area. So for both of these reasons, we would expect there to be some bias towards zero at the cutoff because of the fact that your cutoff isn't exactly correct for some places because of the measurement error. Some people below who would be in the control group and not have access to cell phones migrate somewhere and get access. And so then that would imply that your estimates are biased towards zero. And if you had a real kind of clean measure, these should be scaled up by some factor. Yeah. And at what point do you think that is kind of believable? Because these point estimates are already quite large. And so if you're going to say, after we account for control group contamination and measurement error, these need to be doubled or tripled, that's bigger, a really large impact.
Yeah, that's correct. So we think this is a lower bias, like lower estimates of the effects. Yes, that's correct. Thank you, Michael. James?
Thanks, Elissa. I was just thinking about what Hoyt was saying about people not being rooted to the area, and the fact that this signal is a kind of a continuous spectrum measure geographically. And it kind of made me think like of a different mechanism than the ones you outlined, which is that people who are close to 95 with some error, as Mike pointed out, yes, or have the least travel cost to 95. Yeah. Because they're only a little bit, so like, yeah, in communities I've been in remote, like rural Africa, there's like the phone tree, and everyone knows that tree is where you hang your phone because that's where you get the best reception, and people travel to the phone tree. And having a common meeting place like a phone tree during an Ebola crisis is not great. You can imagine that having a negative, right? So that's just like just a different mechanism, I guess I was kind of throwing out there that Hoyt kind of made me think of, which is that people who are close to the cutoff but not quite there, yeah, have the least travel cost to finding that kind of central spot. Whereas, I don't know if that's something that you've thought about or what your thoughts are on.
Yeah, so I think like I would go back to what, let me tell you what we did, and then maybe if this doesn't address your point. So we thought about it quite a lot. And so what we did was really try to match. So let's say, I mean, you can think about the tree, or you can think about, village 1 and village 2, let's say, village without the tree and village with the tree or something. But so we tried to match village with the coverage with the closest, or vice versa, the treatment and control, the closest, right? Create a pairs of villages, the one that has coverage, one without coverage, and try to estimate the effect on that. Try to take into account whether people would walk over. And so we kind of look at the closest 2 kilometers, 4 kilometers, 6 kilometers, and see whether if you are physically closer to that, what's the effect, with the idea that people can walk to that tree. I'm not sure do you think that's addressed, or do you have another concern?
Let me just, I guess I'll finish my thought and then we can continue, and I'll kind of mull on it. But I guess what struck me about the RD graph you showed was how you saw this spike just below 95, but then it quickly settled back. So it almost looked like just below the cutoff, there was an uptick. Yeah, but then if you go down a few more, it kind of settles to what it looks like it could be a line there. And so I was kind of like, well, what is causing it just below the cutoff to cause a little bump? But then farther enough down, you lose it. I mean, there's other things that could be going on, but one thing could be in a village with spotty reception, people have incentive to get up and move to where they can find the reception. But if you have no reception in your community and you're in the 90 zone, then there's no reason to move around, try to find signal, because there's just no signal. And if you have signal, then you don't need to do this either. But if it's spotty, that's kind of when you might walk a little bit, not to the next community even, but just walk a couple 100 yards to your neighbor that has the phone tree. So I'll keep thinking about it. I just thought I'd throw that out there.
Yeah, no, I think it's a fair point. I think what we tried to do was try to look at that possibility of walking over, and so kind of reducing to the physical cutoff. So even if we consider those people that we can walk over, right, within the 2 kilometers radius, within the 2 kilometers range within the boundary, we still do see the effects. So it's possible. I agree, it's possible. I don't know whether I have it here. Let's see if I can go through it. So I think that's it. So I didn't show you the main results, but they were consistent. I'm going to read in 1 second, but that's what kind of we do. We match villages. And so even if we say, let's say people are close enough and they can walk through that tree, we do still see effects, within the 2 kilometer, 4 kilometer, and so on. But this is a main point in our paper. So if you have more thoughts, please share. That's it. Yeah, that's what we try to do with the data that we have. Try to match those villages and look at whether village that you can actually walk over. I agree with you. That's pretty much what exists. But if you have a better idea, I'm happy to hear those. Thank you. Yeah. So here we were. Here I was. If there are no more questions, I don't see raised hands. Yeah. So basically, the results are about between 9 and 11 percentage points, and with the probing model, the marginal effects are about 7 percentage point reduction. So the other thing that we do that I told you a little bit before is control for the free space signal strand. So to try to basically isolate all those minor changes at terrain topography. So we control for the free space predicted signal and coverage, and we try to identify the coverage just using the variation in the signal strand that is due to all these idiosyncratic changes in the topography. You have all the details that you saw in our model. And the results are consistent. So also controlling for the coverage, the signal strand, or the interaction between the two, you still see a reduction of about 8-9 percentage points in the probability that village has a case of Ebola. So just to summarize and then move to the results, to the mechanism section. the first set of results really show that there is a cell phone, there is a reduction in the probability of getting Ebola in villages with cell phone coverage compared to villages without. We have an alternative specification. I kind of skip it to save some time, but where basically we run a similar regression, but using the panel structure of our data and using Ebola case at the month level. So what we show there is that we do see a contagion effect. So if you, in a district where there are villages with Ebola, also the village we explore is more likely to have Ebola, but if the village has cell phone coverage, that contagion effect is limited, is reduced. And so this, in line with our main results, suggests that there is some important effects of having cell phone coverage in terms of limiting the spread of the disease. The results are robust to some alternatives, to the bandwidth choice, to different measure of Ebola, the number of deaths, or whether, how long you've been affected by Ebola. We also estimate those near cutoff values. So we are looking at specific range for places that are within that cutoff 2 kilometers, 4 kilometers, and then we estimate the walking into coverage, taking into consideration the possibility of walking into the coverage area, as just explained to James. And then we also do some placebo tests where we estimate some sort of fake coverage for areas that did not have coverage during the Ebola epidemic, and we do see that there are no effects. So in terms of, I think the next step is to try to think about the mechanisms that can explain this relationship between cell phone coverage and Ebola. I already mentioned that, so we're trying to see whether there is a network channel and then explore preventive and treatment care channels. We'll try to do that right from, before going in a little bit more of details, exploiting the introduction of a hotline to try to think about whether the network channel is important or versus the care channels are important. So we already know that what is the direction of the relationship. So we already know that the network and care channel, that the care channel should be more important. But what we try to do is to think about whether the network channel or the care channel are more important in a pre-outline or post-outline period. And I was saying you before, we think the network channel should be more relevant in the pre-outline period, because that's where individuals did not have any other choice to rely on their network. The government was doing much. There was nothing, there was not big efforts to limit the epidemic. There were no international aid yet. But instead, in the post-online period, we think that the care channel should be more relevant. So we are estimating, before showing you the graph, let me tell you about the hotline. So the hotline that was set up was a toll-free nationwide phone alert system that opened in August. It really became active in September. But basically, the whole purpose was to create this link between the public and the government, and either people could call to ask a question, or report whether there was a suspect person with symptoms, or even ask for an ambulance that usually would come to take sick people or dead people. And the hotline could also be called to get burial teams and to make safe burials of suspected corpses. So what we do see in the graphical evidence is that this jump is coming mostly from the post-online period. Again, this should not be surprising because there is a drop, and that's what we think the relationship is for if the care channels are in play compared to the network. We are trying to also exclude the network channel. Unfortunately, we don't have, because we cannot really say whether the network channel exists or not. The only thing that we can say is that the care channel, whether that's prevention or treatment, is more at play than potentially the network channel. On average, we do see a reduction in the probability of having Ebola. So we don't have the network, unfortunately, but we try to reproduce the network using historic Liberia clans as a way to define the closest social network. In Liberia, there are about 600 clans. There are a group of 38 villages. If you live in the same clan, you're more likely to be having the same characteristics. So our geographical area well defined is all the chiefdoms. And so we try to estimate the network channel through the clans. So what we want to test is whether the likelihood of an Ebola case would increase if village I has coverage and other Ebola affected villages within the same clan, within the same network, as also coverage. So we create some sort of coverage match variable for villages that are within the same clan. So this is our specification. We have our outcome of interest, that is an Ebola indicator for whether a village I in clan J has at least one case of Ebola in month T. We are then looking at whether there is at least one village in the clan, in the network, that was affected by Ebola in the past. So we should expect this gamma coefficient to be positive. There is some potential contagion. And then we exploit the kind of match variable, the coverage match. That is whether there is basically a match between village I and Ebola affected villages within the clan that also have cell phone coverage. We control for clan and month fixed effect and standard error cluster at the clan level. So what I wanted to show you is that if the network channel was at play, what we should expect is the coefficient on the interaction term match and Ebola at time t-1 to be positive, right? If there was a network channel, then we should imagine that villages within the same clan that was affected by Ebola, but also have cell phone coverage, would increase their interaction, their daily interaction, person-to-person interaction, then would potentially spread the disease even further. We don't see that's the case. And so we kind of exclude the network channel is at play. More importantly, what we want to show is what are the mechanisms going on for the care, whether that's prevention or whether that's treatment. So we do that using survey data that I collected about 6 months after the end of the epidemic. I interviewed about 2,200 respondents in about 600 villages through a combination of interactive voice response and a telephone survey conducted by a local NGO. You can find all the details methodologically in the paper, but this is a phone survey. The key here is that about 30% of the individuals that we were able to interview in 2015, 2016, they were actually living in areas that did not have coverage before the outbreak. And so that's the kind of the variation that we have, 30% with no coverage and about 70% with coverage. So we construct outcome variables that refer both to the preventive care and the treatment care. So for preventive care, we asked people in the survey whether someone came to the village to do contact tracing, explain what Ebola was, hold hygiene meetings, share Ebola prevention information, or bring material or conduct safe burials. This is both prevention in terms of information or prevention in terms of bringing materials and prevention tools. And for treatment care, we have similar question and ask people whether someone came to the village to take sick people or take dead bodies. We also have a measure of whether the ambulance arrived kind of on time. That means, within the 4 hours median that we see in the data through the hotline, whether that was called through the hotline. And then whether community care center will build enough close to the village. So we exploit these two channels. What you can see here is kind of the effects of preventive care, all our measures, as well as put them in an index indicator. So these are standard deviation. The coefficients are kind of important size, but they're not statistically significant. So on average, they are in the right direction. Villages with cell phone coverage are more likely to receive preventive care. The only exception is hygiene meetings. Hygiene meetings were really in person, and so this was not really surprising to us in the sense that if you have cell phone or if you have access to cell phone or radios, for example, it's much more likely to send hygiene information through those media rather than holding hygiene meetings. But on average, we do not see statistically significant effects of being in a cell phone coverage areas on preventive care. When we do explore treatment instead, we do see statistically significant effects. we do see that villages, that respondents of our survey that live in villages with cell phone coverage are more likely to report that someone came to take sick people, that the ambulance arrived on time, and that the community care center were closer. And that's also appear to be statistically insignificant when we put them in an index. So just to conclude, if there are no more questions, anyone has any question before I conclude? Okay, perfect. So hopefully I'm in time. So we provide some evidence that mobile phone coverage help contain the disease. And this is true in our context. It is, in the middle of a crisis, in a setting with general mistrust towards government and other authority. When we explore the channels of impact, we do find that interventions that are designed to improve access to treatment are more effective than interventions that help, increase prevention. And this shouldn't be surprising to anyone in the sense that definitely in the middle of a crisis, the return of the additional ambulance and additional healthcare center has better impacts than additional information and information session on don't wash their hands or what Ebola is. The reason why that's the case is because you can increase prevention, but that's take longer. The effects of that increased prevention takes longer to materialize because you need people to actually act on that information, act on that prevention, and actually change their health behavior. So ultimately, we think that cell phone coverage play an important role in containing the disease. In the middle of the crisis, we should think about exploiting better cell phone coverage and this technology with intervention like the hotline or other type of similar intervention that really improve access to the treatment rather than the prevention. But then we should also think about acting in advance as the next epidemic and think about what should we do in normal times. And in normal times, cell phone access can improve access to the prevention. And so there should be more investment in mobile technology. There is an interesting RCT from some colleagues that really try to test the effects of that, basically randomly allocating new cell phone towers and see what's the effect on that. So it will be interesting to see the long-term effects on that on the next epidemic. But ultimately, we think that we can reduce human economic cost of the epidemic, and we can do that through appropriate governmental action, either in normal times through the epidemic, through prevention or treatment. That's what we should try to aim. So I will stop here, and I'm happy to take any additional question. So Paul, I'm not sure I'm in time, but Hoyt, please.
Hi, I'm going to sound like I'm obsessed with this, so I apologize. But I think on the engineering issue,
yes.
Again, I understand probably on the first stage, you probably can't do it right there in this exact same circumstance, right? Where you have like cell phones in all these places and whatnot. But I think there's like part of the identification assumption is that the raster that you use to sketch out, the signal strength has such precision that it's useful for predicting with super high accuracy spatially. And so you don't necessarily need in your own data to do this, but you could look into the engineering data about I think they talk about the ground truth and calibrating to the ground truth and all these things. And, I think that the underlying assumption here is that if you go to this so-called ground truth data, wherever it was collected, how it was collected, and you say, how predictive is this engineering measure of the ground truth, it has to be extremely highly predictive local to this boundary that you set.
Yeah, that's what I mean. Yeah.
In the extreme, it's sort of like if it's 95 plus epsilon, it's totally different than 95 minus epsilon. And I realize nothing ever works that way, but the point is that there's some way of thinking about what the predictive ability is close to this threshold in the ground truth data that was presumably used to make this index in the first place, right? So I think I understand you won't be able to do like a proper first stage in these data, but I think if you could do a sort of this other think of this as like 2 sample IV or something like that, or it's not even that. It's just more like validation of the identification assumption would be to say, when they initially used ground truth to construct these rasters, just how doggone predictive was it at exactly 95?
Yeah.
You see?
Yeah, no, I do see what you mean. I think like we should probably go back to the data, those data, and explore more. Initially, we, as I was saying, we started assuming that, based on the literature, that's the right cutoff that's been validated. And then we went a little bit further. We got some feedback kind of similar in this sense of, why do you choose 95, right? And so we are doing some additional tests to randomly looking at the range and see where we do see the jump, and where. So there are 3 different type of tests that we run, and all they indicate 95 is the right one for our setting, for the type of network, and so on. I agree with you. We should probably go back and try to present more evidence, because this is the key of this is the key feedback we keep receiving, and so it's important. Thank you.
Yeah, we'll see. Great.
All right, thank you. Are there any other questions?
I have questions and comments, but I think I qualify for the professional development, so I'll just hang on.
All right, well, take
James, you do not qualify for professional anything.
Well, how about development? I study
Well, okay,
development.
yeah,
Can I at
for
least
sure.
qualify for development?
Amateur development.
Amateur development. That's
Yeah.
fair. That's fair.
Yeah.
Okay, well, if that wraps up the questions, I will thank Dr. Maffioli for her excellent presentation, for joining us at PSC this week. We'll close out here, and I will invite our trainees to stay on for a professional development conversation. So,
Thank you for the feedback.
Thank you.
Thank you very much. Thank you, Ida, Michael.
Thank you, Elisa.
Thank you.
Bye.